now, okay. Let me just quickly go and have a look myself. Should be better now, okay. Let's see. Test 1, 2, 3. Da, da, da. Okay, looks like sound is now there. Okay, that's nice. Very good. Let me just check the microphone then quickly. Okay, all right, that's good. Don't need this one. Okay, so a little struggle here at the start, doesn't matter. So welcome guys, thanks for joining in on a Sunday. That's not your normal day when you want to learn radiology, but I think it's nevertheless a good idea to have a go here together, and we will have a look at a knee case, and also feel free to ask any questions. It's more like also a little bit of a Q&A in addition to me going through this case here with you guys. Now, just one other thing before we start. I have something for the Patreons in case of some of you are online. Let me just switch this one here up. So in case you are a Patreon of me, then you can get access to this exclusive Patreon group over on Collective Minds Radiology, and there is basically the case also available. So technically you could go and scroll through the case parallel while I'm doing the stream. You can ask any questions and etc, etc, or you can also go through the case after watching the video just for you. So okay, but I don't want to spoil anything here for you guys. That's why I'm now switching back to the images. Very good. So I think I will do about maybe half an hour, maybe 1 hour. We'll see how it goes and how much actually I can tell you about this case. Now let's start right off here. So you can see here the radiograph of a young patient, 28 years old, and this was done for a trauma. So he had a fall, I think it was skiing or snowboarding. We can immediately see we have the joint effusion here in the suprapatellar recess, and if you look very, very carefully, you can see, or you can at least guess, that there is an additional fragment here, and at that location it's a second fracture or fragment, which is an indication of a ACL injury. And although here in this exam there is no like anterior translation whatsoever, but it doesn't necessarily have to be in this acute setting. So we are now suspecting a relevant or significant knee injury with second fracture and joint effusion, and a few days later the patient then came for the MRI. Now let's have a look at the MRI. What I will now do, I will go through the case systematically, like I would normally do if I am reporting this case. And I typically have the strategy is basically I start medially, then I go to the lateral side, then I go to the central compartment, and then the last one is the femoral patellar compartment. So I basically have 4 paragraphs, each covering one of the compartments. So now, with that said, let's start with the medial compartment here. So I'm going to make it big. So normally I start off with the meniscus, sometimes with cartilage or bone, depending on what jumps my eye. And we can already see here a few things. So first of all, we have bone marrow edema on the posterior side. We have some irregularities here. We will see what that means in a minute. And then there is also a little bit of high signal at the anterior root. Now, the body itself looks quite good up to here. There is something wrong, and the best way to go here is with the sagittal, and we can go here, and you can now immediately see, let's make this big, how we have 2 different components here. So we have certainly a vertical tear here, even a complex tear with extension also here at the base. So the base is basically torn, and this, I think this is a nice example where you can also see this kind of meniscotibial ligament. So here there is a very tiny ligament that goes from the tibia up to the base of the meniscus, and this is sometimes also injured with the whole posterior, medial, corner injury types and the ramp lesions, etc. So we can also see the tear is going all the way here and longitudinally all the way here. Then we have some structure going up here and another meniscus fragment here. So this is also meniscus, and what actually happened is there was some like a flap tear which was then dislocated up here. I think it's even better visible on the coronals. If you go, let me just scroll back here. I mean, it's not very easy to see here, but this is not a normal structure. It's certainly not a normal ligament. So this is also a part of the meniscus, and most likely just maybe a flap, something like this. Then we have this complex tearing, and it was flipped over in this location or position rather. Okay, one very good sequence to go about these vertical tears is always the axial. I like it quite a lot, and it requires a little bit of training, but you can see first of all here, so we have the body itself looks quite good. But then if you scroll a little bit higher up, you can see that there is like this fragment here, and we have also this longitudinal tear here, which then goes up to the body basically. So this line is maybe not so good. So okay, so we have this tear here on the medial side now. Let me make this side by side, so I think we can see this a little bit better. It's now all hidden by text or by chat. Okay, this is lateral now here. So, and if your PACS has a 3D cursor, I think it's a very good tool to use because you can now see where we actually are. So we can follow this tear basically all the way here, and we can see that this is the vertical tear or the complex vertical dominated tear, which is then extending here into this. So this is the base or the red zone or red zone basically, and the joint capsule is inserting there. So we have the joint capsules normally coming down here, and then it goes down here. And we don't have a lot of edema between the base and the joint capsule itself, but it's rather a vertical tear. Nevertheless, I think this qualifies as a ramp lesion. It's a complex tear basically, but we have certainly a ramp lesion, and in addition to that we have this kind of dislocated or displaced meniscal flap tear, and also one component here which kind of lose it here. So we have meniscus substance here, and there it's completely gone. So this one here could be tricky to see, and I think it's nevertheless important to realize so that the surgeon doesn't forget about it. Okay, then as with a suspected ACL injury, let's just establish the ACL injury first. So ACL completely gone, but we will see that just here in a minute. We have the expected bone bruising and the impression here on the posterior or posteromedial corner of the tibial head with the corresponding bone bruising. Now, initially I said something also about the anterior horn, and if you scroll all the way to the anterior portion, we can see a little bit of high signal here. So this is not like how it normally looks like, so it's a little bit swollen, potentially also partially torn or at least injured. So someone is asking, how do I find an Iliopsoas bursitis with ultrasound only? Yeah, well, I mean, you need to have some amount of fluid in the bursa, and I think it's best if you visualize the MR. You just go cross-sectional to the course of the Iliopsoas tendon above the hip, and if you have a fluid collection there around the Iliopsoas tendon, you can certainly make the diagnosis. We used it to make also injections there, but yeah, I think it should be feasible unless the patient is really big, and then it's probably not so easy to make the call. But I wouldn't think why you should struggle there. I mean, sometimes they can be like a subtle irritation, you don't see a lot of fluid, that can be possible, and then it's a difficult diagnosis in ultrasound. But to be honest, I did not really do a lot of ultrasound for this, for diagnostic MSK imaging in Switzerland. Basically everything is MRI nowadays. So, okay. I hope this answers your question. Now, moving on here with this case. So we had covered the meniscus. Basically, we just ended up here with this injured anterior root as well. And now we can also have a look whether the position of the meniscus on the coronal is somewhat altered, but it's not, so it's quite nice here. And then we can immediately see the MCL. It has some soft tissue edema all along the ligament, but the ligament itself, it's okay. We can also use the transverse here. So maybe I need to make this a bit brighter. So you can see here, this is now the origin of the MCL, right? We follow it all the way down. So it's certainly not torn. However, there is mild edema around it. So like very subtle edema all along here. So this is probably like a very mild strain of the MCL, like very subtle injury here. Now, another structure that's quite important now with this kind of injury, so we are still talking about this ACL injury, is the posterior oblique ligament. I have a separate video about the posterior oblique ligament, or the posterior medial corner MR anatomy basically, but you can easily identify the posterior oblique ligament, and it's best seen on the transverse section. So basically what you do, you go to the femoral epicondyle on the medial side, so this is now medial, and this is the origin of the MCL, okay? Now, so this very top here, the posterior oblique ligament, POL, its origin is very close to the MCL origin, but it's a little bit more distally and a little bit more posteriorly. So maybe not here, but somewhere here. This would be the origin of the posterior oblique ligament, and we can somehow imagine that there would be maybe something that could be a ligament, or at least an enforcement of the joint capsule of the posterior medial structure here. So, and here there is a lot of edema, and this is now also an injury of the origin of the posterior oblique ligament, and they are also associated with these kind of injuries of the ACL. I can quickly show you here this kind of posterior medial corner image. If I find it, PM, can't see it. Okay. Now let me just try to find a nice illustration for this. I should have it somewhere. It's just about finding this kind of stuff here. Just gonna try 1 minute. If I don't find it, never mind. We will just move on. So, tac, knee, posterior, Plike, PCL. No, unfortunately, I don't find it now, but we can quickly switch over to the internet. Let's do that. So, and just posterior oblique ligament knee, and just go over to images. You should now see this, and I think, yeah, I think that's okay, this image. Well, it might not be the best, but anyway, I think you can see the MCL, superficial MCL, and just behind it, basically, this is a posterior oblique ligament with running a little bit obliquely and then blending in with the joint capsule. So cannot really see it all the way, but the origin, it's occasionally visible, and here there's a little bit more edema, so I would, especially here, so I would say there is like a proximal injury of the posterior oblique ligament. And then all the rest here is quite okay. Then again, this horizontal, this vertical there. And this was everything for the MCL, I guess. So I hope I don't forget anything relevant here. Now, once we did that, typically what I do next is having a look at this region here to assess whether there is a kind of a Baker's cyst or anything. And please explain more on how to see the meniscal injury on axial planes. Mazen is asking about, yeah, okay, I can do this. No worries. So let me just make a like this, put the axial here and this one here. So what you can use, so you can see the axials now here. Basically you just scroll exactly to the level where you have the meniscus here. You can now see it's about like these two slices here. And you can somehow see the meniscus here. And sometimes, especially small radial tears like this, or flap tears where you have something like this, they can be easily seen on the transverse, and they are a little bit more difficult to see on a sagittal or coronal view. And now here on this one here, I think the trick is to realize, first of all, I mean, it's quite obvious that there is something wrong on the sagittal here, right? And if you now just look here, you could easily mistake this for your normal meniscus. But actually, if you use the 3D caliper, this is just the more anterior portion, like this one here. And the tear is actually here. So what this means, all this is also meniscus, and this is the tear, this high signal here. As I said, it will require a little bit of training to get an idea of the shape of the meniscus on just like two transverse images here. But we can quickly, for this matter, go and have a look at the lateral side. So there are some abnormalities as well. But you can now a little bit see the meniscus here. This is now not the greatest example, but sometimes you can, because it depends on how much fluid you have and also how much your slide thickness is, how much, like even like 0.5 millimeter or something like this, up or down, it varies. But you can get like very good shots sometimes, and you can see really the tip of the meniscus and all the base like in one image, which is kind of nice. And if you then have some linear changes like this or something like cutting out, then you need to be very suspicious of a radial tear at the tip of the meniscus and go and verify this here, because sometimes you just see a truncated tip and here it's like more obvious. So the best thing to do or learn this is just look at the meniscus on every axial scan you get for the next couple of days or exams rather, and you should get a good idea about this. So I think this is a good image, but the difficulty is now to realize that on the next one here is also like this kind of meniscus injury, and then here this displaced meniscal flap tear here, which is going cranially here or proximally. Okay, now I hope this answers your question. Now moving back to the medial side. So once I covered like all the other structures, so Baker's cyst, not really important, nevertheless still writing it down. Then you also want to make sure you have the pes anserine or pes anserinus tendons or fascia, muscles, etc. Everything all right here. Sometimes you can see if they use one of these tendons for like grafting for ACL repair. You can see some scar tissue here, so this is a good indication to realize where they took the graft from. So always look there too. And the one thing I forgot about now is the cartilage, which should be early in the report, obviously. So let me just move this over here because I think the chat is in a way. I should probably make the chat go away from time to time. I'll do that next time, guys. Okay, nevertheless. So yeah, you can see here cartilage. Quite good. Obviously we have some the impression here, cartilage will be injured at least a little bit here, and then so there's no like deep cartilage defects. So here too, like very nice cartilage here, nothing to worry about. Okay, that was everything I guess for the medial side. Now let's move over to the lateral side. On the lateral side, I would start the same way, but since we had this kind of second fracture here, I think it's time to now verify this finding first. And I think it's nicely seen here. You can see here the fragment, which should belong into this corner here. So basically it's an avulsion fracture here. And if you've seen the video from last week about the anterolateral ligament of the knee, we can now quickly give this a check whether it's actually an avulsion of the anterolateral ligament, the ALL, or maybe of another structure. So this is the avulsion fragment, but let's forget about it for the moment. We go now for the meniscus first. So we can have a look at the coronals. I think it's best to start that way. It's a bit high signal in the anterior horn. Body here looks good. This is just like vessel entering the base here. Oopsie daisy. So nothing major. And then here posterior horn, root. Always make sure you have a look at all the planes again. So here we have obviously the Risberg ligament that's entering here. We can see it now for a little bit more. If it's really going far laterally, sometimes it's also a vertical tear, because it's like a zip that's pulling the ligament from the meniscus, and it's referred to the zip sign or zip sign tear, something like that. Not really sure about this one. It's going a little bit more than I would like. We can also try to see this on a transverse again. So you can now see here this black line here. So this is the, I'm not sure if you can really appreciate this now on the stream. We can maybe make it like this. Let's pull them next to each other. So okay, let's make it big, and we use the 3D caliper like this. So you can now see I'm now with my mouse on the Risberg ligament here, and it clearly shows me on the transverse where we are actually. So this is now the Risberg ligament, and we can follow it down here. Some partial volume stuff going on here. So this is still the Risberg ligament, and we can now see how it's entering or narrowing or approaching rather the meniscus base here. So we're now just one slice too high, as you can see here, so we go one down, and so this is basically it. And you can see all the way here. And what you now can see on this transverse, and this is also again an indication why the transverse sections are actually quite good, is that we have this bright structure here between the base of the meniscus and the Risberg ligament. And sometimes they are blending in about at this level. Now this is a little bit more laterally than we would like, so potentially it's also starting to rip it off. And there are some nice illustrations. I can quickly show you. Zip sign meniscus. So let me just switch this here. So I'm just using zip sign meniscus here. So this is basically the idea. You have the Risberg ligament, and it's just, or sometimes called Risberg grip, and it's just pulling or tearing this apart. And white zip sign because it looks like a zipper or like a zip here, and this is the posterior horn of the lateral meniscus. And here again an example from the literature where you can see this kind of finding. But in this case now it's going a little bit more laterally than in our case. You can't see it. I'm sorry about that. Let me just make it like this. Okay. So here you can see how it's going a little bit more here. Just quickly showing you the other images without chat overlay. Here, meniscus, lateral meniscus and Risberg ligament, tearing it apart a little bit, and this is just like the zip here. Okay. Yeah, that's it. Okay. Making chat in and zack. All right. So it's not maybe that obvious like the one case in the literature, but I think it's nevertheless we can suspect at least a tear here. So then back to the sagittal here, make this one big. Now okay, make it big. Okay, so that's this finding here. Then we can see also these changes here in the anterior root or anterior horn. So it's not like an obvious tear, but it looks swollen, it's edematous, and we've got some corresponding, like here there's some edema, we have the typical bone bruising here, maybe even with this cortical fracture here. There's a little step off of the cortical bone, so we have this posterolateral fracture as well, maybe some cartilage damage overlying here. This is just the normal stuff you see after ACL injury, right? So probably the anterior horn was also injured, either by contusion or just some like complex tearing here, maybe like even a vertical tear here. But it's not like fully ripped off out of the bone. Now this joint here looks good, and we can also have a look at the rest of the cartilage, I guess. Let's just have a look here. Tibial side, it's quite good. And then we have the femoral side, which is also quite good. And no bone marrow edema on the femoral side. Okay, now moving on to the ligaments. Lateral, collateral ligament, certainly the first structure we want to have a look at. And we can see the origin here. Let's make this big. It's a little bit too bright. It's not like the normal black structure we are used to. We can quickly verify this on this transverse image here. So basically all this would be LCL, and we can see this fiber, for example, here. If you are going up, we kind of lose it, even this one, so some of them we kind of lose it. Then we have more posterior portions here, they are intact. So I'd say it's a partial tear, or even down here looks a little bit strange, but this more posterior aspect is intact. Okay, so far so good. And if we are now having a look at the ALL, so let me just pull up this illustration from my last video. How can I show this to you guys now? Maybe like this. So hang on a second. Just trying to show you this here. Yep, and then we do, yes, so okay. No. So let me just try this. Okay, I think that's okay. Yeah, so you can see here the ALL has a similar origin with the LCL. This is from the last video, and it's running anteriorly and then down here and inserts between the half of the distance between Gerdy's tubercle and this one here. So that means if we are now going back to the case here, we go to the transverse, for example, first, make it big. So they have the same origin here. So potentially some of these structures that I just mentioned might actually be part of the ALL. We can now try to verify this on this kind of coronal image here. So this is now posteriorly going anteriorly. We can see this kind of, now this was posteriorly and this is anteriorly. Okay, so here, somewhere here should be the ALL like this. Maybe better seen here, or maybe if you follow the video, it should have this kind of orientation. And what actually the second fragment should be is an avulsion of this meniscal or meniscotibial component, or the tibial component as it's sometimes referred to. So we can now try to think what actually is inserting here. It's really hard to see, right? So this means now either this component is also injured, which is most likely the case because we can't see any obvious like ligament-like structure here, We see a little bit here, but then this kind of black line vanishes and it's all dirty, and so it will be a partial tear at least of the tibial component. And even here we don't see like this smooth ligament that's going up here like the meniscal component of the ALL, and certainly we cannot see anything covering here the lateral inferior genicular arteries or artery and vessels here. So just in theory, if you go back to the illustration, I can quickly blend this in. If you look at this one here, so what should be the case now is we should have a ligament inserting here, and then maybe something like this going here over here. I don't know, something like this. So it's a very hard ligament to see, especially in an acutely injured knee. But together with the second fracture, I mean, we can't see any obvious structure. I think it's fair to say it's partially torn. Why is it not fully torn? I would argue if you have the avulsion of the ALL, the bone was weaker than the ligament, so we have the avulsion, and we should not have a complete tear of the ligament, although maybe it's also completely torn. Who knows? But just from the, yeah, logically, either the ligament or the bone is weaker and tears or gets avulsed. But I think it doesn't really matter as long as we point out to an injury of the ALL in this patient. So going back to the transverse image here, we see Caris tubercle and the iliotibial band inserting here. We can see the LCL. So the ALL basically is just in the middle here. So we are looking at this region, and we can see it's actually quite the case. So we have this fragment here, which is just in the middle between these two structures. It's avulsed from the lateral tibia here. And in other cases, you could technically, or you can really see this ALL here, but here it's all swollen and edematous. So I think there's not too much more to say about this kind of ALL. So if you haven't watched the ALL video from last week, I recommend you go and have a look at this right after this stream, because I think it would just point out a few things in more detail, I guess. So Mike is asking, can you point out the Mpfl and distinguish between medial patellar retinaculum? Thank you. Okay. Do you use outer bridge classification for describing cartilage? Yeah, so Mike, for the outer bridge classification, I don't use this classification for cartilage damages because, first of all, I think there are several classification systems out there. So if you want to use it, make sure your surgeon uses it as well. And what I don't like about it is if you have a focal defect which is going all the way down to the bone, like, I don't know, maybe something like cutout defect like this, then you would have to give it quite a high grade, whereas overall the knee might look quite good, or the rest of the compartment might look quite good. So what I do, I just describe the size. So if I have a defect like this, I describe the size, ideally in two planes, and the depth of the cartilage damage. So I typically use superficial, half of the thickness or more than half of the thickness, or like all the way down to the bone. These are kind of my descriptive terms I use to describe cartilage defects. I'm not a big fan of any kind of classification systems outside of research studies. There are other people that use it all the time. I mean, it's just a different way of approaching the thing. I think, especially if you don't have a orthopedic surgeon, for example, as a referring physician, you can confuse the GP or someone like that with this kind of classifications quite a lot if you don't give the explanation what it actually means. So that's why I prefer just to stay descriptive. And for the other question, Mpfl. So yeah, I go to the Mpfl once we are at the, no, we can quickly do this, that's fine. So the medial patellar plica or plica basically is this structure here. So the plica, so we are on the medial side here. And if you have this kind of joint effusion, basically you can see here this synovial fold here. It's just a fold of the joint capsule. And this is the plica or the medial plica. And this is now like a normal plica. Then it goes down here and we kind of lose it somewhere there. So with Pleco Syndrome, what you want to look out, or what you have to look out, is basically this structure. If it's swollen, if it's thick, if it's edematous, and normally if it's not really reaching into the joint, it's not really symptomatic. So it's more likely to be symptomatic or actually causing problems if it's large and if it's thick and if it's swollen. It's not so common, and sometimes you get MR after a resection of the, or debridement of the medial patellar plica, and then you go to the previous MR before surgery and you don't see a lot. So probably sometimes during surgery there might be a little bit of irritation, and then they make this call during arthroscopy, but we sometimes really have a hard time to see this on MR in my experience. And you can always also look for corresponding cartilage damages here on this medial aspect of the femoral patellar joint. As for the Mpfl, so basically what it does, it's connecting the patella with the femur, and it runs down in a broad explanation just like that. So we can have a look at this, for example, on a sagittal or even a coronal. Let me just pull this in. So Mpfl. So now with this amount of effusion, it's quite hard to see, but sometimes if you have not that much effusion, you can see, if you scroll here from this view on a coronal now anteriorly, you can see the Mpfl as a broader structure, sometimes even a little bit striated, inserting here onto this kind of thing. Potentially, I'm not sure if you can see this on the stream, we have some striations there, here. I'm not sure, I can even go bigger. Let's try this. So you can see this kind of striations here, so probably this is part of the Mpfl. But then, having said that, it's kind of not at the same location as the medial plica. Where are we now? So, okay, let me just make this like this. So because the plica, it goes inside the joint, and the other one is just running down here. I'm not sure if this answered your question or whether I misunderstood you. Ah, you mean the retinaculum. Oh, I'm sorry, not the plica. I'm sorry. Yeah, well, I mean, the Mpfl is basically just, in my understanding, just a portion of the retinaculum. So the retinaculum is a little bit more. Sometimes the retinaculum is very thin, and the plica is like, the plica, what am I talking about? So the retinaculum is basically this broad, everything that's going down here. A little bit like a fascia or something. And the Mpfl, the ligament, is just like this enforcement of this kind of thing. Because if you do Mpfl reconstruction or anything, you don't fix all of the retinaculum. So this is just my understanding. So the retinaculum can be even something like this, very thin, but it's not at the right location. And if you go a little bit higher up, then it's where we actually see this enforcement sometimes. This is now not a good example to really see it. And if you have dislocations, you can see obviously the avulsions on both sides here. So I misunderstood that, Mike. So I was thinking you were talking about the plica. Sorry about that. Okay, got it. If it's still not clear, just write me down here. We can have a look at it again. So I think we were on the lateral side. I was just wasting a little bit of time here. Alrighty. Okay, so we were covering cartilage and the second fracture, and then this kind of partially torn or incompletely torn ALL. The iliotibial band looks good. Gerdy's tuberculum looks good. That's good. Popliteus tendon. So the popliteus tendon is is a little bit high signal up here, but it's frequently the case. I'm not really sure what to make out of it. Most of the time, if there was no trauma, people tend to give tendinopathy, but I feel like every knee has tendinopathy of the popliteal tendon, so maybe we are just overcalling that one. So probably nothing major happening here. It's a little bit high, but it could be normal, it could be not. So I wouldn't spend too much time thinking about the popliteal tendon here. Now, one thing that you can see in injured knees is edema at the myotendinous junction of the Popliteus. So down here in this region you can have kind of strains, etc. So always make sure you give this a look. Then what else? So obviously the proximal tibiofibular joint. We don't want to miss any kind of fractures or anything, but it looks good. What we have here is muscle edema though in the extensor digitorum longus and tibialis anterior muscle, so the anterior compartment, and even the the fascia looks a little bit irregular here. So we kind of can't see like the smooth covering here, so maybe we even have some kind of a myofascial injury at this level, just below the second fracture. So maybe it was also injured together with the ALL and the second fracture. Then there's other soft tissue injury here, which I think is quite interesting and is frequently forgotten about on knee MRI, and this is the distal quadriceps musculature. You can see we have quite a lot of edema in the vastus lateralis here, and I think we've got another plane where we can see this better, like here. Oh, let me just go all the way down so we can see this kind of a little bit of edema, and on the sagittal, maybe that's even the better sequence. Now you can see all this edema here. So even there was a relevant muscle injury. You can argue now, is the muscular architecture injured or not, but certainly there was a relevant muscle injury here too. So always give this a quick look. And what else? I mean, it's always good to have a look at the nerves as well. Common peroneal nerve here. So we don't see a lot going there. And I think that's all for the lateral side. Now moving on to the central compartment. So obviously, and we have discussed this already in the beginning, we have a full thickness ACL tear, so there's nothing going down here. And I think I like the transverse sections quite a lot. We see a little bit of ACL up here, then it's completely gone, then some things are coming down here, then we have this kind of irregular structure here, which we will have a look at in a minute. The sagittals are also like very good in this case. You can see how we have the distal portion, and then we see a little bit up here, and the rest is completely gone. As for the PCL, for me it's a bit too high signal here, so maybe mild injury of the PCL here as well. Yes, I mean, now the other thing I wanted to show you here in this case is basically here this structure here. So just think about it. What could it be? What do we want to call it? Now, I mean, there are basically two theories, right? First of all, it's not fat. So if you just have this one here, technically it could be just some fat from the Hoffa's fat pad, but it's not. It's also dark here on this PD. And what we don't see anymore is the infrapatellar plica. So the infrapatellar plica normally goes centrally to the Hoffa and then inserts up here, something like this. And here we can see the Hoffa here. This is just a cleft here, and nothing really attaches the Hoffa up here. This is a finding you sometimes see after arthroscopy, but you can have also injuries of the infrapatellar plica. And this was certainly the case here. So we have a full tear of the infrapatellar plica, and this kind of thing here, it could be some blood clot, it could be part of the torn ACL, although I would then imagine some connection to the ACL, which is not really the case. We can see some extension here to Hoffa's fat pad, so maybe this is part of the torn infrapatellar plica. So they will certainly see this during arthroscopy. Yeah, Mike, that's absolutely correct. It's the inferior plica tear. And I think this is really nice. Why is it important? Sometimes in a mildly injured knee, it can be like it can be an isolated finding, basically. You can have isolated tears of the infrapatellar plica and not much else, and you can really give a good explanation for the patient's problems or pain if you see that. Okay. So I think that's all for the central compartment here. Now moving on to the last compartment, which is here, femoral patellar compartment. And we can see the cartilage here, quite nice. We can see a lot of effusion, and this is now certainly some blood clots after hemorrhage initially, now forming here in the superior recess. Now the tendon, quadriceps tendon here is good. Patellar tendon looks also unremarkable. Quickly checking this on a fat saturated image as well. A little bit of high signal down here, but it's always really not so easy to make any judgment about it. I mean, we see this frequently on the origin of the patellar tendon, and there it's believed to be like common unless it's like really fluid-like or if it's swollen or something. So this is certainly just within normal limits. And down here, I don't know, I probably did not describe this when I was reporting the case, and just going down here, maybe not relevant anyways. I think that's probably the key information here. So I would probably, to make it a little bit shorter, not overcall this as any relevant pathology. Now obviously always look for loose bodies. Can't see anything here in the recesses. Sometimes we really have to make sure we are not, or maybe make sure we have the correct windowing settings to not overlook any subtle findings. But unless, yeah, we just have this kind of clot, but also we are not missing cartilage. So if you have a big or like a deep cartilage defect, something like this, then we should really go and look for the fragment. Just one thing I'd like to point out: cartilage defects are frequently missed on the posterior aspect of the condyles, and so always go and check this region here. So you can have very big missing pieces of cartilage and it gets not noticed occasionally. So this is kind of a hidden site for us to look at, because you would think, oh yeah, I go cartilage here in the joint, it's all good. But yeah, we should go back also to the posterior aspect of the condyles. Yes, that's it. Okay, basically that was the approach for the knee. The last part is normally also just have a look at the popliteal region of joint, anatomic variants with the gastrocnemius heads, etc., accessory muscles or anything like it, Baker's cyst I already mentioned, also tibial nerve. Just go through this and just go for that. Maybe just one thing. Sometimes you have a lymph node up here, which is completely normal. This can be confusing sometimes. Yeah, but I think that's all I got here. So if you don't have any more questions, I think I will stop this now. I think it's already 10 to 9, and I should get some rest for the coming week, where a lot is going on. So thanks for watching, and give the video a like. I think you can do this also on a stream, and hopefully see you next week. Bye bye.